comes in. So the importance of starting now with developing these outcome measures and agreeing on them is that when you come to after the pilot is done or during the course of doing the pilot, you can actually do an evaluation with the measures that you really want to use. So finally, how can the state best use the outcome data? It's a straightforward process to analyze outcomes data while controlling for differences across plans in the characteristics of the consumer. So some plans will say to you, well, my consumers are much more disabled than somebody else's, so it's not fair. But there are statistical ways that somebody like me can do easily. It's not complicated. So you can adjust for differences in the plan, and then you can compare the plans one against another. You can compare the plans over time, and the state agency that is presumably responsible for oversight can compare across the state and identify problem plans, problematic areas within plans. The state can then promote improvement within the plan, or change the contract or change the plan when necessary. And with experience in doing this, I think performance standards might be established based on these outcome measures, and then plans might be actually required to meet them, or perhaps better yet, given financial incentives to improve upon those measures. Outcomes should also be tracked over time to make sure that services do not deteriorate as more people are switched to manage long-term supports and services. And data should also be made available on websites, on state websites, to allow for consumer comparison and targeted advocacy towards certain plans. Thank you.
Thank you very much. And now you get the last word.
Oh, no.
Last word. Briefly, last word.
I will try to keep it very brief. First, to go back to the original purpose of this hearing, Olmstead implementation is, just as I said, should be codified as one of the purposes of IHSS integration into managed care. The Olmstead purposes in independent living should be codified as measure or outcome that is assessed one way or another. So first. Second, we found in our advocacy that this program is particularly difficult for limited English proficient beneficiaries to navigate, and so any successful outcomes in my mind would do a better job reaching underrepresented populations who have a hard time navigating the benefit. And third, there must be some sort of legislative oversight wrapped up in whatever the quality assessments is. I don't think this is something that can be left simply to the plans, and I don't think this is something that can be left simply to DHCS or DSS. Thank you so very much.
Okay, that's great. Senator Emerson.
Is it our intent to develop some policy legislation from this hearing today, or what's the?
There are two bills. There are two bills.
So that's what this. Okay.
Yeah. You let the cat out of the bag. So. Yes, there are some discussions.
I'm thinking Will's going to want to get out of town here pretty soon.
No, I don't think so. Thank you very much. Let's bring Mr. Lightburn back up for a minute. I think the LAO has left, so. And this is us working together well.
Hey.
Yeah, right. You've heard the comments of the testimony today of folks concerned about the integration of IHSS into the managed care plan, and I don't know. Do you have any takeaways? I mean, I think I have three, and I think Anna. I pretty much would agree with Anna's last three comments, but.
The first thing, if I may, Senator,
Sure.
is Senator Lewis, Senator Emerson, is thank you for the hearing. The process, the dialogue that's been going on around this broad issue over the last 3, 4, 5 months in public and before that with stakeholder groups has been really very developmental in that both the plan has been evolving, and several people commented on the trailer bill as released yesterday, as have the commentaries been evolving.
Correct.
And which, to my mind, is exactly the whole point. It's to try to get better understanding and closer. Although earlier Frank Mecca sort of framed three issues, and I think that you could almost put the commentary even as developing under the three. The issue of consumer protection, building on the existing program, and setting the right pace. I mean, as being sort of the set of concerns sort of fit there. And if I could just sort of quickly walk through, I mean, I absolutely agree that it's been a hugely successful program, both from a county operational point of view and now
Sure.
state level. It has been an enormous success, and to the extent that it has had a weakness that has been sort of historically frustrating, I think I mentioned this in the Budget Committee hearing, it's that we've never been able at the operational level to capture the savings that the program's accomplishing. So we've been in this paradoxical situation where we know it's meeting the needs of people. We know it is a very productive, cost-effective device, and at the same time we're watching it get eroded because there's no way to balance where the savings are moving. So our commitments have been to preserve the core of the social model by preserving the consumer rights and protections, their choices, build on the existing program, preserve the county involvement. In terms of sort of the question of sort of developing out the assessment tool of the future, Senator Hancock earlier was sort of asking where have we looked. I mean, we've looked at Washington State, Oregon, Minnesota. There are useful components to each, but the programs they're running are different, and they're not as focused on home and community-based services as we are. So inevitably we're going to wind up doing something that is California, and we very specifically said we want to build it off the existing IHSS assessment tool because that's proven, and the hourly task guidelines are proven. It had an enormous investment of stakeholder development in it. So build off that, and then attach to the extent that individual consumers and different presenters today have sort of reminded us that people are in different places and have different needs, to the extent that attaching medical information and assessment serves particular people well, attach that piece. Mr. Mecca sort of inquired whether there was a sort of an omission or commission in the trailer bill about optionality of the coordination teams. The intent, I'm speaking from memory, but I think I'm right, the intent is that it's only optional to the extent if someone absolutely does not need the medical components, then let's not do a whole big coordination team. If they have those needs, then we want to be sure they've got the coordination team and that the county's involved in that. And on the sort of the evaluation discussions that have been sort of just in the last few moments, as well as earlier Frank's comments about sort of the need to have a clear path to evaluation as we start. Absolutely agree, and it's part of the work groups that we're planning to start with stakeholders in the next weeks. And both sort of the CWDA involvement, Dr. Kay, who's obviously enormously familiar with this, and the Olmsted perspective, I think, have to be built in to our evaluation assumptions, instruments, processes. Within the IHSS program, currently we survey consumer satisfaction, have a very nice high consumer satisfaction rating. We don't want to see that lost, but all those other domains, health, well-being, family, functionality, etc., have to be built in. And then finally, just the observation I'd make on pace, on small p, as Frank said, pace of how we move. We don't want to mess it up. I mean, and I'm not the final word on it. You the legislature are. At the same time, I'm always conscious of windows and moments. I remember sort of, it was like 18 years ago when AB 1040 was passed, and we were thinking, we're going to get some coordinated care models, and we were never able to get it to happen. I think right now we have sort of the wind with us, and if we build in the right safeguards and we preserve the right consumer protections, I think we can get this done. And candidly, as we sort of observed before, we're in a budget inhospitable moment where doing nothing is a very unattractive option, at least from my perspective, sort of as with the operational responsibility for the program. So that's my takeaways.
All right. Thank you. Any further comments from members? You're all worn out. Let me just, today we try. Staff has done a very wonderful job about shedding this conversation in the light of the Olmsted and your trailer bill language does not mention that. So we'd like an opportunity to make sure that we're doing things that are amenable to our developmentally disabled folks. The second thing is we're talking about outcomes, desired outcomes, and a process to get there. I mean, how are we going to articulate that is something of concern. The third thing is legislative oversight of the process and what is going on. After 3 years, what happens? So, those are some of the issues that are concerns that we have, and hopefully, as you move forward and come back, for further conversations. And I know that we have to get a budget out in a couple of months, but this is part of a conversation that I hope that we will continue to have. And I do know that after the last conversation we had about dual eligibles, and with this conversation today, that we're working on something, aren't we, guys? Yes? Yes. Okay. What do you mean? Don't know.
I actually do have
a little comment.
A little comment and sort of a question. I appreciate where you're trying to go. Well, I guess my two questions are: I don't understand where the savings come in. And maybe the reason is that it seems to me counties would have just as much incentive to try to keep people out of nursing homes, if that's where the savings comes, than a managed care plan would.
Well, currently, Senator, counties don't have any share of cost for institutional long-term care, for skilled nursing care or intermediate care. They have no share of cost for it. So the counties I've worked in have worked very hard to try to be the alternative, because it's what people want, it's what the consumer wants.
Because that is
but as you know, I mean, and I say this with nothing but regret. I mean, over the last few years, we've had to pull money out of the program just as a budget balancing mechanism, even though we know the utility of the program, because there's no way of clawing that back, and that's what this does. Is it lets us do that.
And then I really appreciate what you're saying about the window of opportunity, because I think we're seeing that in a number of places. But but really, is the pace doable? I mean, to me, that's all the pitfalls of not getting it right.
One hates to to promise and that you can't deliver. But certainly, in all of the conversations I'm party to in the administration on implementation, there's a very, very conscious eye on it. Doesn't if something doesn't make sense or some plan is not ready, we don't start. We move it to wherever. And I realize that at some point in this process, and I'm not necessarily experienced enough to know quite when, that has to get codified between us. But
yes, I understand that. Okay, before we close the hearing, I just need to announce the votes for SB 1060 was 4-2, and SB 1064 was 4-0. That was a long time ago. And I will stay for public comments if there are folks who have public comments. And thank you all for staying. Yes.
May I beg you to stay one moment more? Because I had to restrain myself to Olmsted comments, and I have very strong feelings about consumer safety medically under this program. Thank you so much. I appreciate it. Maybe I watch Dr. Phil too much, but he says, you can judge the future of something by what's going on now. Right now, people on the 1115 waiver are missing dialysis. They're missing surgeries. They're losing transplants. I talked to Elena Ackle of LA Legal Aid. A sister gave her sister a transplant. There was such a slowdown in giving her medication to keep her body from rejecting it, she almost lost her sister's kidney. I'm not seeing anything here protecting consumers. Nothing. You know, in Hawaii, they were sued because a doctor said there aren't. They're saying there are doctors in that plan and there's plan sufficiency, but there's not. That when she was trying to send her disabled and elderly patients to the plan, there were retired doctors. They weren't really there. And Hawaii was permitted to sue the plans for that. And what they had there was at least a redundancy, which was if you went to your plan and they weren't ready for you, you got to go back to your fee-for-service provider. Nobody from the state is stepping up. You know, when I hear Mr. Lightbourne speak, I'm always happy. I don't know. This may get me in trouble. I'm not a politician. But when I hear Mr. Douglas speak, I'm not so happy. I'm hearing things that don't gel with what I'm seeing. I'm not seeing an accountability by the state to stand behind the people currently being injured. There should be a safeguard that this plan is way too aggressive. I mean, you have a pilot project, and it's called the 1115 waiver. You had a pilot project on IHSS, and it was called the Tulare County Managed Care Project, which I've linked to you in my comments, which was 65% more expensive with additional administration costs and profit. And there was an unprecedented amount of terminations of people from the program, impositions on family providers to do things for free. The Robert Wood Johnson Foundation showed that managed care corporations did not show an improvement in patient outcomes or in the cost of things. And as a person who cares so much about rehabilitation, I've seen what the insurance companies have done to my people. They have given them too little rehabilitation and institutionalized them. So I beg of you, please, I think the operative word for the whole afternoon was what Deborah Doctor said. You're experimenting on people. You must have redundancies in place. You cannot hurt people's health with impunity. Also, the ability of a disabled person to see their specialist. There are pulmonary quads who have had their Rancho Los Amigos polio doctors for 40 years. I am a breast cancer survivor for 17 years of 2 bouts of breast cancer. My doctor knows the pathology of my tumor. He decided whether we take off 1 breast or 2. I'm being followed every 3 months. If I get a bad test, I want him. But there isn't an exemption to go to the doctors who you have a long-term relationship with. It's only for 1 year. So, you know, you've got to realize the healthcare industry is booming right now. The baby boomers getting older is creating an environment where people want to create an industry. And the consumer, I contend to you, will be overwhelmed. I ask you to please look at the consumer protections that we put in the IHSS Consumer Union, to also talk about if there were any lags in your medical care or your attendant care, that these be seamless until something's worked out. But I still think this is reckless in light of the 1115 waiver, and I beg you to find some way. Talk about perverse incentives. Look at Tulare County. Why not get the counties a way to claw back the savings of IHSS? Why not, instead of hurting people, why not claw back the money within the system? Why not work that way? Thank you.
Thank you very much. Okay.
I just have a comment. I know there's many in this room and some of my colleagues up here on the dais that support a single-payer health plan. Where do you go after that plan? You're asking for flexibility in healthcare, and I agree with you.
We must see our doctors, our specialists. We must have an exemption that doesn't just last a year.
Thank you. Okay, we have time for public comments, and I know people have been very patient, so please join us up here and state your name. See you tomorrow morning. Right. Thank you. That's fine. Thank you very much, folks.
Hi, my name is Mark Beckwith. I'm on the Alameda County Public Authority Advisory Board, member of Northern California ADAPT. And my mind's getting numb. There's been a lot of stuff said here today, and a couple of things stuck in my mind that kind of struck me that a lot of people they don't really get what independent living is all about. You're listening about medical this and medical that, but I think that the independent living centers and other organizations, public authorities, are going to be really valuable. I mean, I don't understand trying to put IHSS under managed care, but you need people with more of an independent living aspect. I know that I heard some talk about standardized training, and really the reason that makes my attendants uniquely able to take care of me is because of specialized training that they got from me. And sometimes if I'm going to the doctor and they're there with the doctor can show them something, a nurse, that they might have to do. But generally, I can't see as where standardized training, there is no standard. I mean, it's like one size fits no one. There are seniors that are going to really benefit by the managed care and the case managers and all this guidance and stuff. But those of us who have been there and done that are rolling our eyes like, oh God, they're going to care management team. You know, I know what I need, just listen and write it down and it'll be all set. And so spending money managing me is kind of a waste of money because there's somebody else I have to buck to get my way because I'm kind of independent at this point. Maybe overly so, but I just wanted to say I wish there was a way to recognize the specialized training that my attendants do have, because I'll be in the hospital and I'll hear people make comments about attendants as untrained, and I'm thinking like, wait a minute, these nurses haven't got a clue what to do, and the one person that knows how to take care of me is the one they're calling untrained. So I think if any recognition is going to be given for training as far as being worth a higher salary, I think it should be the people who know how to take care of me. I mean, there are thousands or hundreds of thousands of nurses and nursing assistants, but there's only like a dozen people that know how to take care of me. And when I'm really sick, I can't really explain things. Sometimes I'm kind of out of it and not really able to explain things in detail, but there's certain little things that a nurse isn't going to know. I don't care what kind of training, how good it was. For instance, my head is turned a certain way. It cuts off my breathing. I can't say anything. I make a little sound like, and my attendants know what that means. But if I'm in the hospital and you do that, the nurse got no idea what I'm doing. They'll just keep cutting my air off. So, you know, it's really scary having to deal with people that are untrained. But it's really scary when people don't recognize who the trained ones are. And I think that, I know there's a lot of paranoia going on in the disabled community right now. And we hear things like, oh, don't worry, IHSS and the county social workers will be there for another 3 years. It's like, well, what if we live longer than 3 years? I'm kind of hoping to. I don't know if I will. I'm kind of past my expiration date anyway, but I'm not planning on going anywhere soon. And I'm just hoping that people will recognize who the real experts are in independent living, and it's not doctors and nurses.
Thank you very much. Yes.
Karen Kiesler, California Association of Public Authorities. I'll be very brief. There are reasons that there are differences between public authorities on training standards and registries and wages and so forth. And you've heard through the afternoon that one size fits all. We really applaud the trailer bill language from the administration that preserves for some period of time the public authority role at the local level while we figure out the right way to integrate services. The last thing I want to say is to quote a parent that testified yesterday in Senate Budget Subcommittee number 3 on DD, where she was talking about big system changes there, and her question was, if you don't get it right, will you have time to do it over?
Right.
Thank you.
Thank you. Thank you very much.
I know it's late.
We're still here.
My name is Jim. I'm on the Alameda Public Authority Advisory Board. I'm scared. I've been simply about 3 hours. Why here is the IHSS and managed care. I worked for almost 10 years full time. Part of my job was getting people out of institutions. I'm on the board of Caritas. Very proud of being involved in the Coffin case. People have worked so long getting people out of institutions. Don't let this happen. Don't let it happen. Please don't.
Thank you. Thank you. Okay. Is there anyone else who would like to testify? Yes.
I just have one question. I'm sorry, my name's Adam. I'm an attendant, a provider with IHSS. And one thing I don't hear being brought up is, how do you take something that's like minimalized financially, put in a middleman, and expect to save money? I just don't get that. I've heard no one talk about it from SEIU or any of the unions or from the hospital side or anything, that you add someone that's getting paid nicely, he wants to send his children to college, and you expect to save money. I just don't get it.
Appreciate that. Right. Thank you. Pointing up, yeah. Yeah, right. Anyone else? Well, I thank you all for persevering the afternoon, and it was a very interesting comment. Thank you for your participation. I hope it's not raining too hard out there. And we'll see you in a couple of weeks. Meeting adjourned.